come back. I'm sorry our breaks were a little short or non-existent in the case of the first session. We have now the perhaps most exciting part of the event coming, but before this is the roundtable discussion. I would like to make a very brief announcement and very briefly share my slides to make this announcement. It will take only 30 seconds. I would like to remind you to follow us on Twitter, ProPASS, but most importantly, we're advertising a non-remunerated scientific events lead at ProPASS for someone to help us with putting up events like this. Please get in touch with us via Twitter or in the generic ProPASS address if you know any or if you're interested. And with no further ado, I would like to have the pleasure to introduce the moderator for the roundtable discussion, Professor Marie Murphy. Marie is currently an honorary professor at the University of Edinburgh and also a professor at the University of Ulster in Ireland. And Marie had a major role in the development of the UK physical activity recommendations. She led the adults physical activity. So thank you, Marie, for joining us today. I know 3 hours is a big ask as a favor. It's a great pleasure to have you. The floor is yours.
Brilliant. Thank you very much, Manos, for the introduction. And it is really lovely to be here. I was delighted to be asked to chair this panel discussion. As a physical activity researcher who started my career as an exercise physiologist, I've always been a little bit frustrated that both intermittent and short bouts of physical activity, and to a lesser extent, the intensity of that activity, which we know are the stimulus for so many of the health benefits that we derive from activity, are either ignored or not adequately captured by questionnaire methods. And that this data derived from questionnaires then has such a big influence on our approach to guidelines and therefore the messages we give to the public. So I've been fascinated by the talks, and I'm delighted that we now have an opportunity to pose questions to the speakers. So thank you to all of the speakers, first of all. On behalf of the people who were listening in, I thank you. They were fascinating insights, and they really raised questions about the potential and the pros and cons, I suppose, of device-based physical activity, how that should influence our future guidelines. And I think it has the potential to radically change the evidence base, but we've heard reasons why that might be slow to come, and also from Karen, the challenges in that in terms of measuring not just physical activity, but also domains and other parameters. So we have Fiona, Jacob, Matthew, Joe, Peter, Annemarie, Manos, and Karen back with us. And we're going to ask you to use the question and answer function or the panel to ask your questions. And what we're trying to think about, is this a good time to move from questionnaire-based physical activity and sedentary behavior guidelines to accelerometry ones? Or is there scope for both, as I think we've heard? And if we are going to make the move, what's the best way to ensure a smooth transition? So I'm kicking off there and I suppose asking anyone to type questions and maybe tell me who you are and who your question is addressed at. And then I'll allow any other panel members who want to come in to join into the debate. Okay, maybe we'll start with the first one that is sitting here from Kaja. A question to, oh, Jasper, did that disappear? Sorry, as you'll soon discover, I'm a little bit of a technophobe. Yeah, okay, so Jasper, you're already answering it, but perhaps we'll give you the mic to answer it. How did you select your sample in your study? So just picking up on Jasper's, and then perhaps that will give other people a time to type more general questions addressed at the whole panel. So Jasper, over to you. How did you select your balanced sample of 7,500 invited participants? So I think this is speaking to some of the bias issues.
Yeah, exactly. So thank you for the question, Kaya. We tried to do our best to get a device-based sample that was very, very similar to the population sample that we started with. So in our survey, we asked people, can we contact you again? Would you be willing to participate in a device-based study? We had a lot of people say yes to this, many more than we had expected. So that was a positive thing. But there was a slight bias in that group, almost 40,000 people that said yes to being contacted again. So what we then did was to make sure that we had, a similar number of men and women and differences in education level and things like that in the 7,500 that we invited for the study. So that's how we tried to balance it so that the people invited for the accelerometer study, they were similar to our population-based sample.
Okay, thank you, Jasper. I'm seeing a question from Rosemary. I think in this, trying to catch up with it. So a general question from Rosemary. Do the speakers think that by the time of the next guidelines, and we heard mention there of 2027 for the start of the development of WHO guidelines, do you think by then we will, or even indeed should, have new evidence on these aspects of behavior? And if so, how do we get there? So this is things like duration, the pattern, the timing. I'm going to start by throwing that over to Peter, because he has had the best indication of how the guidelines were developed. So Peter, can I start with you?
Yeah, I guess that's a pretty complex question. I think, as we've heard throughout the morning or the evening here, I think the device-based measures will really kind of help pinpoint issues of duration, intensity, associations with health outcomes. Now, the degree to which that will impact the messages around the guidelines is still an open question, and we had a question about that in the chat. Because some people really follow their devices. They may be wearing a Fitbit or a watch or something. Others are still going to revert back to kind of their impression of what they're doing in a day. And we all know that that's very biased, and they may not understand exactly how much time they spend sitting, for example. So it's going to be very complex, I think, to take the device-based measures and try to translate that into something that the general public could follow. Like Manos gave an example earlier this morning about 60 minutes of vigorous activity. Someone's going to the gym and they're saying they're doing 60 minutes. But in fact, they may only do 20 minutes of activity during that time. So if you tell someone they only need to do 20 minutes, well, they just go to the gym for 20 minutes now and only do 5 minutes of activity. So it's going to get pretty complex pretty quick, I think.
Yeah, maybe if I could throw that across then to Karen, because Karen, I heard a little bit of skepticism or a little bit of concern over trying to move quickly to accelerometry-based guidelines or evidence for guidelines, and maybe a worry that if we did that, we would miss some valuable stuff. So maybe over to you to see whether you think that by 2027 we'll be able to do this.
Thanks, Marie. So I think by 2027, we will certainly have some really good evidence that's derived from devices. So for the 2020 guidelines, we had very little. I think the Ulveckman paper had just come out. We looked at it, we realized it was valuable, but we had so much evidence from self-report. We couldn't do much with this one study from Ulf, or, the handful of studies. The work that ProPASS and others are doing will certainly ensure that we have a lot more evidence to look at, and we certainly should look at that evidence. We definitely shouldn't ignore it. It's providing really useful insights. It's providing different information to what we've previously had. I think the main challenge we're going to have is how we grapple with these two different stories. So if self-report tells us one thing and devices look to be telling us something quite different, what do we do with that information? So do we put more weight on the self-report because there's a higher volume? Do we put more weight on the devices because we think that they're more reliable? So I think it's going to be a very interesting time during the next guidelines. It's certainly going to be more complicated than it was last time around. And then there's this issue with how we then communicate that. And I think that that's a really good point just raised by Peter about if people say they're doing an hour and they're only doing 30 minutes, if we tell them to do 30 minutes, are they going to do 15? So how we then use the guidelines to create messages for the public about how active they should be, I think is then a second challenge that we really need to get our heads around in the next 2 years if we're going to do a decent job of the guidelines, which will, the WHO will review the evidence in 2027. And if it's deemed that there's a sufficient new body of evidence to inform revised guidelines, then the process will start for 2030 guidelines.
Okay, thank you, Karen. And you've almost picked up and started to answer Sonia's question, which came in during that, which was about the messaging, because of course, the more complex this becomes, then the more difficult it is to message. And I'm not even sure that we have correctly messaged the existing guidelines, and Sonia points to the fact that that's something that we're still hearing the remnants of 5 by 30 and indeed earlier guidelines before that. Okay, Manos wants to come in, and then Jacob, I presume, on that last question. Manos.
Thank you. I think I totally agree with everything that both Peter and Karen said. I will be very surprised if we move to device-based guidelines only. I think the transition will be smooth, slow, and will perhaps take 2 or 3 cycles of the guidelines, if ever, for the guidelines to be purely device-based. So I think, in my opinion, the first candidate of what component of the guidelines to be based on accelerometry data is stepping guidelines. We already have seen a lot of activity on that front, particularly with the UK Biobank. ProPASS stepping is, of course, the thigh accelerometers can measure stepping very well. So I think it's going to be modular in a way. So we will see recommendations and sub-recommendations, perhaps based on device-based evidence, perhaps the headline guidelines. I'll be very surprised. It will be very hard and very challenging to simply scrap them and come up with different amounts all of a sudden. So I think it will be a gradual process. Overall, it will be a gradual process, and we will see components of the guidelines based on accelerometry data rather than the whole guideline kind of dismissing questionnaire evidence and saying that from this point on, we only consider device-based evidence. And this cannot happen because some of the longest term cohorts will still be questionnaire-based cohorts. We cannot dismiss one type of evidence in favor of the other. Thank you.
Thanks, Manos. It reminds me, for anyone who has lived through a currency change in your country, where you moved from, say, sterling to euro or one currency to another, having a cliff edge cutoff point causes lots of confusion because people suddenly have to redo things in terms of currency. So it suddenly reminded me of that. Okay, Jacob, and then on to Peter.
Yes, thank you. I really echo Manos' comments here that there will be a gradual process, but I think we will never go away from having to use self-reported information because it captures things like context. So resistance training. We are quite a long way from capturing that with devices, and I also think it's important to consider that. So there's a lack of global representation in the guidelines right now, but if we move to devices, we will really be focusing in on a very specific section of the world, and I think we should be careful in going in that direction. Yeah, thank you.
Okay, thank you. Yeah, we're going to miss domains and context quite a lot unless we can find a way of capturing them. Peter.
Yeah, this is just in response to the comment by Manos. And, he mentioned an evidence base perhaps that comes from accelerometry and even thigh-worn accelerometry for stepping, and how that would inform an evidence base, which is actually very, very good. But then when you try to translate that to the public who are using a watch or on their cell phone, it can also count steps and all this, or a pedometer, which is also very different. All of these types of devices give you different answers in terms of the number of steps per day. And how well does that compare to the very well described thigh-worn accelerometry. You know, Katrine Tudor-Locke has done a lot of work in this area and has shown, you know, that the sensitivity to steps in a pedometer is very different than an accelerometer, and well, depending on the device itself. So if we go out and we say you need to do 8,500 steps per day based on the data, but then that doesn't even, you know, doesn't correlate with any of the devices out there, you know, how are we going to overcome that? I guess we're going to need a crosswalk among the devices, but it's just changing every day, right? We have new devices on the market every day. How do we keep ahead of that curve? I think that's going to be an issue.
Yeah, brilliant. Thank you, Peter. Annemarie.
Thank you. I wanted to just give a brief comment on the going back to the pattern of activity. I think this is typically one of the things we can study really well with using accelerometry data, very difficult with questionnaire data. So I actually hope that we can at least say something if we need to spread our activity over the week or not, or if it all in one day is also okay. I think the challenge there is to keep it a bit simple, because I also experience working with data scientists. Of course, they can come up with these very difficult ways in looking at patterns, and it's great to relate it to health outcomes, but it's impossible to translate it into something useful. But I think the simple way of just looking at how we spread activity over the week could be very useful. Thank you.
Yeah, that resonates with me, because in terms of my own background, it was the fractionalization of exercises where I first became interested in this. And I think it is often lost in the kind of questionnaires that we've used to date. Okay, Jasper and then Karen.
Yes, thank you. It's a great debate to see, and I see there are more and more questions coming in on the Q&A as well. So that's really good to see. And what I wanted to pick up on is sort of turning it upside down and saying, okay, well, we know there are a lot of issues with measurements, with devices, all those things. I'm also quite confident in that a lot of that will get solved along the way. Total harmonization, probably never going to happen, but we'll learn a lot along the way. We'll get better and better at it. But that still, to me, does not answer or solve the issue of, okay, but what is it that we're actually going to communicate, first of all, to our health professionals in terms of guidelines, and potentially to the public in terms of guidelines? And if we as measurement people find it difficult to figure out what to do with measurements, perhaps the way forward is flipping it upside down and say, okay, if we involve communication specialists and say, okay, well, what type of messaging would be useful for health professionals? That might help us direct our research in terms of, well, what is then the type of device-based evidence or measures that are useful because they can be used in messaging? So yeah, different perspective perhaps to help us narrow down and focus where to use our attention the next couple of years.
Yeah, so some information may be more useful for the messaging than other information, and that might be where we want to focus. Okay, I'm keen to move on. Karen, something very brief, and then I'm going to move on to one of the more recent questions that have come in.
It's fine, Marie, move on.
Okay. I'm going to jump on one here that I see in from Dale, and again, it kind of resonates with me. Should we be thinking about other device-based tools, not just accelerometers? Should we be consider other sensors for heart rate or other vital signals? Any panel member want to jump in on that one? Manos.
Yeah, thank you. Thank you, Dale. This is a great question. What we have seen in the last 10, 15 years is, so accelerometers have been used in research for some 30 years in physical activity research, 25 years perhaps in epidemiology. And circa 2010, 11, we saw commercial trackers, Fitbits, and consumer devices, let's say, with accelerometers being released. And what happened during this time, in this last 10 to 12 years, is that in terms of the technical specs, I mean, the consumer devices are miles and miles and miles ahead of the research-grade devices, the accelerometers. They have more sensors, they incorporate more sensors all the time, they can measure all sorts of things. type, intensity, lots of different things that well beyond what we can measure with research devices. So I believe that the reason for that is that the manufacturers of research-grade accelerometers are too small, and perhaps they don't have the capacity to innovate and embark on larger projects and add sensors. But I think it's a matter of time. I think it's a matter of time that eventually heart rate sensors will be incorporated, gyroscopes, altimeters to be able to measure uphill walking and stair climbing. And in my opinion, although it will somehow add some complexity in the evidence synthesis process, to me, this is a really exciting development because it will keep giving us evidence to be able to generate, to understand the health attributes of different aspects of the physical activity pattern with a view to providing more options to the general public about how to meet guidelines and how to be physically active and how to gain from doing physical activity. For example, the example study I mentioned in my opening presentation about UK Biobank analysis showing that two bouts lasting up to 2 minutes each of vigorous intensity physical activity per day associated with 35% reduction in CVD mortality risk. Why would you not want to target short bouts of vigorous intensity physical activity? They provide comparable kind of effect size with meeting the 150 to 300 minutes of self-reported physical activity. So I think it is a matter of time, and it will be an exciting development to add some more sensors.
Yeah, and building on that, it's certainly an easier way sometimes to persuade people to be physically active in those really short bouts. And we also had a lovely response there to that question from one of our delegates, saying that it also allow us to look at light exposure, and we know that the effect of that. We've done some work on myopia in children, and that is related not just to physical activity but to light exposure, and these new sensors will allow us to get a lot more data, although the complexity is really mind-bending. Okay, I would like to move on to a question from Rona here, and I think she raises a really important point. We surveillance and trend data and how we're doing over time at how our policies are affecting physical activity is important. And if we move away almost the same way as every time we change the question that we ask, it's really hard to track physical activity. So maybe if I throw this first of all to Karen, what about the issue of surveillance and how device-based measurement might influence or affect that?
Thanks, Marie, and thanks, Rona, for the question. So I think a couple of things to say. So obviously we don't want to lose our trend data. So even if the surveillance tool that we use doesn't mirror the guidelines, because the guidelines change, it does allow us to at least monitor progress over time. And I think that that's really important, more important than the proportion of the population that meet a threshold or not. I think if we can see progress, I think that that's a really useful indicator. I also think that if we develop guidelines based on devices, we may need to consider using devices for surveillance. I think we're not in a position at the moment where guidelines will be purely device based, and maybe we will never reach that point. But if the guidelines are heavily informed by device-based data, and we know those data are different to what we get from self-report, I think it would be inappropriate to undertake surveillance using self-report of device-based guidelines. So that's going to throw up a number of challenges in terms of how we collect device-based data at scale, whether it's using research-grade devices, whether it's using mobile phones. All different methods are available. And to reiterate Jacob's point, we really need to ensure that we don't widen disparities between what we know about physical activity participation in high-income countries versus other settings. And I know that that's a key agenda, for ProPASS, is to reach more low-middle-income countries. And that's one of the reasons why ISPA partnered with ProPASS to try and make sure that we don't neglect those low-income countries as we move forward with this agenda, because obviously the data does come from Australia, the US, and the UK or Europe.
Okay, thank you, Karen. Jasper, you gonna maybe come in there?
Yes, I could, but I was thinking about the next topic you wanted to start with.
Okay, thank
So,
you. I'm following a chat and I'm following questions and answers. So yeah, we're going to move now then on to the question that is raised by Sonia. And Sonia's asking really about people with chronic conditions, because of course the guidelines are meant for them as well. But if we take the device-based measurement at a single time point when they are needing to be inactive because of their condition or unable to be as active, how might that cause us a problem? So Jasper, this is the one I think you're going to come in on.
yes, so I think that's a very valid point, and probably it's even more important to think of this when you are talking about people with a chronic condition or people that are recovering from an operation or any sort of other big life things that mean that their activity levels fluctuate over weeks or over months or over the year. So that's another perspective of measuring, where obviously in a survey you can ask back a year, and even though there's a recall bias, you can still get some information looking back longer in time. But then, as Manos also mentioned, and some of the questions also hinted at, with a lot of the consumer devices, yes, they might not be perfect measurements, but one of the big advantages of them is that they will give you measurements over a very long period of time. So again, there might be opportunities there, especially for these groups where this measuring over months or years, perhaps even, is important. We might be looking at, well, okay, well, instead of a device that really has a very, very high measurement validity, perhaps go to a device that has a reasonable measurement validity, but can be worn for much longer. So there are, again, things to consider there. But I agree very much with the point that one time point is often not enough.